The Zebra Farm, written by James Noake. These are cases from Dr James Noake and they will be in a series released over time. This is sponsored by PhysiQuip and you can get 3 years of Physio Matters premium access if you buy equipment from PhysiQuip. So click the links around this audio and you can go there and get that. In musculoskeletal medicine, we are trained to recognise patterns. Most of the time, the answer sits comfortably within the familiar. Overload, strain, tendinopathy, but every so often something doesn't quite fit. The story is slightly off, the response to treatment unexpected, or the clinical picture is just a little too inconsistent. This is where the Zebra Farm comes in. Each time we explore a trio of real-world cases as written up by Dr James Noake, consultant in musculoskeletal sport and exercise medicine, in his new book, Real-World Sports Medicine and Musculoskeletal Case Studies, Knee and Lower Leg. The cases challenge diagnostic instinct, presentations that look routine on the surface but reveal something far less obvious underneath. These are not just rare conditions for rarity's sake, they are reminders of the cognitive traps we all fall into, anchoring pattern recognition, bias, and premature closure. Because sometimes when you hear hoofbeats, it isn't a horse. This is the Zebra Farm. Case 1. The compartment syndrome that wasn't. Myotonia congenita. A runner and footballer in their late 20s had endured a 10-year history of bilateral lower leg pain described as crampy and bursting. Everything pointed toward chronic exertional compartment syndrome, or CECS. Rapid symptom onset with running, involvement of multiple compartments, anterior being worst, stiffness and subjective weakness after activity. They had even undergone bilateral fasciotomies with no improvement. Something didn't add up. On reassessment, muscles felt woody and rigid post-exercise. There was increased muscle tone noted and delayed muscle relaxation. Power improved paradoxically with repeated effort. MRI showed diffuse calf oedema bilaterally, but nothing focal. The crucial clue came from EMG. Myotonic discharges producing a classic dive bomber sound. Further testing showed mild changes in the deltoid too. Diagnosis: myotonia congenita, a non-dystrophic neuromuscular disorder, not a compartment problem at all. Why it fooled everyone. The patient looked muscular due to doing isometrics 24/7 for 10 years. Imaging looked consistent with exertional pathology. Long history reinforced diagnostic anchoring. Key sign: symptoms didn't fully settle after stopping exercise and they improved with repetition, warm-up phenomenon. Note, though, this warm-up phenomenon is short-lived. Transition: where muscle pain isn't muscle at all. The first case teaches us that abnormal muscle physiology can masquerade as mechanical overload. The next case pushes this even further when the pain isn't muscular at all, but vascular. Case 2. The nerve entrapment that was a clot, perineal vein thrombosis. A patient in their 40s presented with 3 months of deep lateral calf aching, worse with activity but now present at rest and at night, localized towards the lateral calf. Referred as possible superficial perineal nerve entrapment. They also had significant history, prior contralateral DVT, avascular necrosis of the hip. The imaging changed everything. MRI neurography revealed marked oedema in the flexor hallucis longus region, oedema centered around the perineal vessels. This raised suspicion of something non-mechanical. Duplex ultrasound confirmed a perineal vein thrombosis. Diagnosis: deep vein thrombosis mimicking MSK pain. Why it fooled clinicians. Localized lateral calf pain suggested nerve pathology. Gradual onset, not acute. Key sign: pain that progresses from activity related to constant, especially with night pain, should raise suspicion. Bigger picture. This case also highlights underlying systemic risk. With recurrent thrombosis and AVN, consider possible antiphospholipid syndrome or systemic lupus erythematosus, or SLE. Transition: when imaging is subtle but the symptoms are loud. The first case was metabolic, the second was vascular. The third returns to muscle but challenges our understanding of what a muscle injury actually looks like. Case 3, the imminent tear or soleus central tendon injury. A runner presented with 3 months of deep mid-calf aching, described repeatedly as an imminent tear sensation following cramping. No single traumatic event. Performance and speed limited, and runner has to pull up and stop when symptoms appear. Clinical pattern. Low level activity is manageable. Threshold reached, sudden escalation of pain. No bruising, no classic tear presentation. Imaging findings. Ultrasound, soleus central tendon injury with loss of definition and subtle hypoechoic changes. MRI, central tendon aponeurotic disruption within the soleus. Diagnosis, soleus central tendon injury. Why it fooled clinicians? No pop or obvious tear, minimal early clinical signs, ultrasound sensitivity is poor, roughly 27%. Symptoms felt disproportionate to findings. Key sign, deep progressive calf pain with a threshold or pre-tear sensation without trauma. Closing reflections, patterns that should make you pause. These 3 cases highlight a shared clinical truth. When the pattern doesn't behave like a simple strain, it probably isn't. Across all 3, symptoms persisted beyond expected timelines. Pain behaviour was atypical. Initial diagnoses seemed plausible, but incomplete. The real challenge isn't recognising rare diagnoses, it's recognising when a common diagnosis no longer fits. Practical takeaways. Red flags in routine calf pain. Night pain or symptoms at rest. Bilateral or multi-compartment involvement. Long-standing symptoms with failed standard treatment. Disproportionate stiffness or muscle tone. Neurological or systemic history. Think beyond muscle when symptoms don't resolve after rest, not a CECS pattern. Pain improves with repetition but only for a short time, maybe myotonia. Symptoms progress despite offloading, and pattern is inconsistent with imaging. Always consider alternatives. Neuromuscular, myotonia, metabolic myopathies, vascular, DVT post-thrombotic syndrome, aponeurotic/tendon, deep muscle architecture injuries. Clinical mindset shift. Don't anchor on the first reasonable diagnosis. Reassess when treatment fails and let pain behaviour, not just imaging, guide your thinking. In MSK medicine, the sound of hooves is usually a horse, but in calf pain, it's just often enough a zebra to matter.